Hi, this will be a continuation of your discussion on neurologic introductions. Now, class, in this chapter or in this specific section, we'll be talking about assessment. Okay, so this is the employment of your several assessment skills, particularly your IPPA, and then the typical or the specific signs and symptoms for neurologic problems. Now, for your assessment, now, in the assessment of our clients, of course, we will start with subjective data. For the demographics, we would want to know age, sex, and occupation. Now, pay particular attention on age. Related to the aging process class, one of the effects is that there is lower nerve conduction velocity, meaning the transfer of signals from one nerve to another tend to be slower when they were younger, okay, compared to when they are young. This results to delayed response to multiple stimuli, and then the tendency is for them to have slower reflexes. Now, there is also slow retrieval of information from long-term memory. So with this, they are manifesting your age-related forgetfulness. Furthermore, there is a slower response to changes in balance. So your patient is at higher risk for falls, and they are easily distracted and would have the decreased ability in maintaining their attention. So if you can notice, your old adults would usually jump from one topic to another. They are unable to focus on the answers that you are giving them. So this is related to the neurologic changes on their physiology. Then class for the sex, okay, stroke is more common among males. And then for occupation, the higher the stress associated with job, the higher the risk class for neurologic dysfunctions. For example, you have nerve problems such as your Bell's palsy and your trigeminal nerve neuralgia, which could be aggravated by the stress of the patient. Then we would also want to know the chief complaint of the patient. Okay, so class, if the patient comes into you in the ER, for example, because of slurring of speech, you need to first determine whether the patient had loss of consciousness prior to that incident. It may be possible that your patient lost his consciousness, and then when he regained consciousness, he already has slurring of speech. That would signal that your patient have had a stroke. Okay, the likelihood of stroke because of that presentation is higher. Then for the common symptoms. The symptoms for our neurologic problems tend to be subtle or intense. It could be fluctuating or permanent, and then it could be inconvenient or devastating on the part of your patient. There are disorders, class, wherein there are periods of remission and exacerbation. So when I say remission, the patient is experiencing relief from the signs and symptoms. They are not continuously experiencing it. Okay, only for them to find out that after a year or after some time, there is exacerbation. So when I say exacerbation, class, okay, there is an increase on the signs and symptoms, and then probably it's more severe compared to the previous attack. Then for the pain, okay, pain could be acute or chronic, and your pain could be a signal of brain hemorrhage. So class, how come brain hemorrhage? Okay, your patient may be experiencing throbbing pain, and this throbbing pain, class, may already be your pulsating aneurysms. Okay, recall aneurysms, the outpouching on your blood vessels. So whenever your patient, class, would complain of a sudden throbbing pain, and then later on the patient lost consciousness, that could be, class, a sign of your hypertensive, okay, hypertensive hemorrhage, okay, or your hypertensive stroke, which means, class, that due to the increased pressure going towards the brain, okay, it led to the rupture of your aneurysm. Also, your pain, especially class the chronic type, could be found among your patient with spinal disc disease. So when I say spinal disc disease, due to the compression of the spinal nerves related to the narrowing of your spinal cord or your vertebrae itself, class, okay, it can result to chronic pain. So we use commonly the term sciatica to refer to chronic back pain, and we also have the condition spinal nerve compression. So class, in spinal nerve compression, as the term implies, the spinal nerve was compressed. This compression could be related also to your fracture, especially if we're talking about patient with osteoporosis that led to porous brittle bone, and then later on, class, it would possibly rupture, or it would possibly collapse, your vertebrae, leading towards the compression of your nerves, leading towards pain. Furthermore, your patient may also manifest with seizures. So class, your seizures are considered to be abnormal electrical discharges. Okay, your patient will manifest with alteration in sensation, behavior, movement, perception, or even consciousness. Now take note, okay, of several kinds of seizure. It is your generalized disorder that could cause the lost level of consciousness. In your pitimal class, in your pitimal seizures, okay, or your pitimal epilepsy, you don't expect your patient, okay, to you don't expect your patient to be shaking. Okay, class, the tendency in pitimal seizures is that few parts of the body is moving involuntarily. Okay, you also have your absent seizure wherein your patient would be staring blankly at you. Okay, as if class absent-minded. No? For that reason, it's referred to as absence seizure. Okay, so class your seizure, the important thing there is that it is caused by abnormal electrical discharges. Then you have your dizziness. Class, your dizziness is brought about by the abnormal sensation of imbalance and movement, whereas your vertigo is usually associated with vestibular dysfunction. This vestibular dysfunction, class, is related usually again to the functioning of your ears. Remember, your ears is also in charge of balance and equilibrium, other than your ears being a sensory organ. Okay, plus your patient may manifest with spatial disorientation, lightheadedness, loss of equilibrium, then nausea and vomiting. Now, on the visual disturbances, okay, there is decreased visual acuity related to aging. Other than that, your blindness is very common also. Class, blindness is usually caused by glaucoma. Okay, if not glaucoma, you have diabetic retinopathy as one of the major causes of blindness among your old adults. Okay, class, when I talk about glaucoma, just remember that in your glaucoma, there is an increase of intraocular pressure. Okay, your glaucoma, class, deals with increased intraocular pressure. Now, to that effect, class, if this pressure is not relieved, okay, that could lead to blindness. And the blindness could be permanent on that part. Okay, once, class, there is already blindness, it could be permanent or irreversible already. Next, you also have your muscle weakness. So class, muscle weakness tend to be sudden and permanent, especially if I'm dealing with a patient with stroke. So if you will ask them when did the weakness occur, they would just say that they were eating, then they suddenly fell, and then there is already weakness by the time he woke up. Now, when I talk about progressive muscle weakness, this usually refers to your degenerative muscular disorders. Okay, then you also have your autoimmune neuromuscular disorders. One example, class, is your ALS. Your ALS is your amyotrophic lateral sclerosis. The next part here, class, is related to the history of trauma or falls involving the head or the spinal cord. Now, class, if your patient had an injury to the head and the spinal cord, okay, you have signs and symptoms or you have diseases that can develop across the years. Okay, so you need to check, class, if your patient had this history, because if your patient had a history of fall, they will be at higher risk of having fall measures also. Okay, so then we have your objective data. So class, for the objective data, the most important there is your level of consciousness. Class, your level of consciousness will be able to say something, okay, about the functioning of the brain. So your level of consciousness could be alert, okay, it could be obtunded, it could be stuporous, and then it could be coma for your patient. Then class, cognition. When I talk about cognition, this refers to knowledge. Okay, so class, if there are discrepancies already on the knowledge of the patient, you would suspect that there is damage, okay, on a certain part of the brain. Then you have your pupil size and response. So recall that the pupil size normally is at 2 to 3 millimeters. Now, if you're dealing with, if you're dealing, class, with a patient with stroke, it could be that the pupil is dilated. It could also be constricted. Now, the response of your pupil should be summarized by PERLA. When I say, class, PERLA, P-E-R-R-L-A, so pupil is equally round and then reactive to light and accommodation. Now, try to review your handouts in your health assessment as to how to accomplish the assessment of your responsiveness for the pupils. Okay, then class, you have your verbal responsiveness. So this is already a component of your GCS. We are also evaluating your extremity strength and movement. Okay. So, for the mental status class, we are checking and assessing for the appearance of the patient. Then for the appearance of the patient, that would involve assessment of the dress, the grooming, and even the personal hygiene of the patient. We also check if the patient is alerted oriented times 4. As I have previously mentioned to you, okay, so class, your alertness and orientation times 4 would mean time, place, person, and purpose. Okay, so to evaluate for mental status, you need to ask those questions. Then you have your memory. So you have your recent and then your remote memory. Obviously, class, when I say recent, that would mean yesterday, that would mean last night, that would mean last morning. Okay, so class, your recent memory loss is usually happening first compared to your remote memory loss. In other words, class, your patient has the tendency to remember, okay, the people that they met 5 years ago but unable to remember that concept at present. Okay, then class, you have your repetition of your 5 to 7 numbers. Then you have recall 3 items after 3 minutes. Then recall address, recall meals, and then possibly recall the presidents of the Philippines. So asking about the presidents of the Philippines for the past 3 terms, for example, okay, would mean class that the remote memory of the patient is still intact. Okay, so they're able to tell you stories of 20 years ago during the war or 30 years ago during the war, but unable to recall class their meals. That's the tendency of the old adult patient. Then class, you have your intellectual functioning. For intellectual functioning, we're doing a quick check of the arithmetic of your patient. So simple questions may be count backwards from 100, then subtract 7 from 100. Now, you may give your patient a proverb, okay, I'll say a quote, and then you ask your patient to have an abstract reasoning for that quotation. Okay, class, judgment about the situation. So, for judgment, you might be asking your patient, what will be, or what will the client do in case they forgot to bring his house key? So, what could be the alternatives for that? Okay, so class, when I talk about judgment, okay, meaning that their judgment about the situation is prudent. Okay, when I say prudent, it is what the vigilant nurse would do in case the need arises if on asking questions if this could be done or not. So the common question class to test for judgment is, for example, you're inside a building, okay, which is having a burning building as of present. Okay, there's fire in the building. Now, class, what would you do? So if your patient will say, oh, I will just sleep out and then relax. Okay, then what your others may say, oh, I will run and grab this and this. Okay, class, with that question, you are testing the judgment of your patient. Then you also need to assess for the thought content, which would involve assessment whether the thought is spontaneous, clear, relevant, or coherent, and whether the ideas are fixed ideas, illusions, or preoccupations. Class, problems with the thought content are usually associated with psychiatric-related problems. Then you have your emotional status. So you'll be usually looking into the mood and the affect of the patient. Now you'll be looking into the affect, whether the patient is irritable, angry, anxious, apathetic, showing you flat affect or euphoric affect. Now, you also need to check if this affect is consistent with the mood of the patient. So that's why we have the verbal and non-verbal consistency as part of your assessment. Then we have your language ability. So this is to check whether the client can answer the questions appropriately. Can the client read and explain its meaning? And then can the client write her name or copy a simple figure that the examiner has drawn? So class, these abilities would in fact be able to detect for the presence of abnormalities such as your agnosia. And then class, this could also detect the presence of your aphasia, okay, meaning the inability of the patient to communicate, okay, or to understand the one that is being communicated to her. Then class, you have your level of consciousness. So level of consciousness will be the person's wakefulness and the ability to respond to the environment. Class, this is the most sensitive indicator of neurologic function. This is usually related to your ability to follow a command. So once class, the patient is unable to follow a command, we proceed with the expression of your noxious stimuli, okay, until we'll go towards your painful stimuli. Okay, for us to understand that further, let's go towards your GCS scoring. So class, your GCS scoring is the primary tool that can evaluate the neurostatus of your patient, specifically on the level of consciousness also. Now, once the patient class, by the way, would have decreased level of consciousness, and then class, the motor and cranial nerve functions will become the priority of your assessment. Okay, so you don't think of other things. Okay, perform your motor assessment for us to know the specific type of stroke of the patient, or at least for us to decide on the management of the patient. So class, this slide would illustrate your GCS scoring. So you can see here that the perfect score for your GCS is 15, and then the perfect score per component is as follows. For eyes, you have 4. For verbal, you have 5. For motors, you have 6. So as mentioned earlier, you first proceed class with their ability to follow command. So you'll be checking if they are able to follow, okay, your command before you proceed to noxious stimuli, before you proceed to your pain. Okay, it is not possible for you to perform GCS assessment by starting on application of pain. Okay, so class, first start with command and then followed by noxious stimuli and then followed by pain. Okay, again, do not start your GCS by using pain. Now, class, the highest score for GCS is 15, the lowest score is 3. The patient is considered to be in a state of coma if the GCS is 8 and below. Class, the lower the score for GCS, the poorer the prognosis of your patient. Again, the lower scores would indicate poor prognosis on the part of the patient. Then class, when you are doing your GCS scoring, okay, you might need to do or to remember your abnormal flexion and your abnormal extension. So class, your abnormal flexion is referred to as your decorticate. So when I say class decorticate, okay, if you would look at the picture, the upper arms are close to the sides of the elbows, wrist and fingers are flexed. Okay, class, the legs are extended with internal rotation and then the feet are in plantar flexion. So that's decorticate. When I say decerebrate, class, the lesions of the midbrain pons and the encephalon, class, are the usual reasons for this. Okay, so class, your decerebrate, the neck would appear to be extended with the jaw clenched, the arms are pronated and extended and close to the sides. So class, the legs are extended straight out and the feet are also flexed plantarly. Okay, so class, if you look at it, the site affected for your decerebrate are your midbrain pons and the encephalon. So, if you're going to decide between the two, which is considered to be more severe, is it your decorticate posture or your decerebrate posture? So class, with the inclusion of your midbrain into decerebrate posture, that would imply class that this is more severe compared to your decorticate. Then, for the assessment class of your cranial nerve functions, okay, so we need to compare the right and the left side. Okay, that is for the purpose to determine whether the damage is unilateral or bilateral. Now, the key cranial nerves that you need to assess are cranial nerves number 2, 3, 4, and 6. Again, it's cranial 2, 3, 4, and 6. Now, you should have already noted that the left half of the brain is controlling the right side of the body and vice versa. So, cause a damage on the right side of the brain, okay, will cause problems on the left side of the brain. So class, this crossover, okay, or we refer to as decussation earlier, occurs just between the medulla oblongata and then the spinal cord. Okay, so class, you need to be able to realize that so that in assessment, if you know that your patient is having left-sided weakness, you know that you will be paying particular attention on the right side when you're viewing the CT scan images. So class, just as a quick recap on these major nerves, so you have your optic nerve, which can be assessed by your Snellen's chart and newspaper. Okay, and so this is how your Snellen's chart would look like. Added to that class, your 3, okay, that would be concerned with EOM. Your 4 class is also EOM, then your 6 is also EOM. Try to differentiate class. For number 3, okay, so this talks about eye movement towards the nose. On the other hand, class, your 4 would talk about test for movement at the eye of the test for upward eye movement. And then class, for your number 6, of course, it's the lateral movement. So class, to assess for your extraocular movement, you'll be instructing your patient to close one eye, then to follow the fingers through the visual fields. Okay, so class, this would be able to accurately assess whether the damage is on the left side of the eye or the right side of the eye. Then okay, you need to test for conjugate movement. So class, when I say conjugate movement, that will be the time you ask your client to look as far as possible to the sides, up, down, and obliquely. Okay, so that's your test for conjugate movement. Of course, damage or presence of your conjugate movement may indicate damage to your eyes. Okay, so picture showing nystagmus. Then you have class for your pupils. I mentioned earlier about perla. Then it should be at class, when I say pupils, the normal findings is that they are isochoric. Okay, whenever class we say that the pupils are anisochoric, you would notice that, okay, so there is unequal pupil size. And then class, we have what you refer to as your Argyll-Robertson pupil. These are bilateral small pupils that reduce in size on a near object but do not constrict when exposed to bright light. Okay, so class, meaning it's reacting to the object but it is not reacting to the bright light, which is contradictory because you would notice usually that we have already an effect of this. We also have already the effect. Then for your CN5 assessment, recall that this has both motor and okay, so some say marry money, but so this is both motor and sensory. So that's why class, you would be assessing the jaw movement, And then you'll be also checking for the masseter and then the temporal muscle, because these are all elevated by your cranial nerve number 5. So look at the diagram on the right. That will be the location of your temporalis muscle and then your masseter muscle. Now, so this is how you'll be doing your palpation. Okay, just to check for tenderness and then also to check for the motor functions of these muscles, because these are the ones that would be innervated by your trigeminal nerve. So if your trigeminal nerve is damaged, we would not expect movement from your temporal and then masseter muscle. Okay, then you have your physical findings. So I would like to touch on some physical findings that can be found among patients, class, who have neurologic problems. So one is your unilateral neglect. When I say, class, unilateral neglect, this is the tendency of the patient not to put attention to one side of the body. Okay, because the patient thinks that that side of the body may be problematic. So class, for that reason, okay, your patient is not giving attention to that side, unilateral neglect. Common among patients who have had stroke. Then you have your mask-like face. So class, when I say mask-like face, if you can notice, if these people, class, are either smiling or even if they are mad, class, so the tendency is that their face would appear like that of a mask. Okay, look at the Lola there on the right side of the screen. That is an example of a mask-like face. Okay, so it's referred to as that because there are no to minimal movements. Then you have, class, your aphasia, dysphonia, and dysarthria. Now, when I say aphasia, this is defective or absent language function. Okay, there is a problem on language function. When I say dysphonia, there is a need to change in the tone of your voice. Okay, so this can be found in the paralysis of vocal cords. Then, for dysarthria, class, your dysarthria. So class, when I say dysarthria, this is a difficulty of speaking. So seen usually in the damage of your upper motor neurons, lower motor neurons, even your cerebellum and then, or cerebellum, I mean, and then your extrapyramidal tracts. Okay? Now, the next terms will be your other physical assessment findings would be your agnosia, apraxia, and aphasia. So agnosia, class, okay, usually your patient is described as not able to know. So class, this is the inability to understand the meaning and importance, okay, and even the symbolicism, okay, of ordinary sensory stimuli. Okay, so not knowing, you are unable to recognize common objects. That may be agnosia. Then, when I say apraxia, class, apraxia is the inability to perform voluntary acts. Okay, so inability to act is your apraxia. Then you have your aphasia, which is the inability either to understand or express. Plus, the usual definition of aphasia that we encounter or use arbitrarily is that we consider those who are unable to express themselves as aphasic. But in fact, class, inability to understand and inability to express are both considered to be aphasia. Now, there are several kinds of aphasia. Look at this, class. Okay, your Broca's aphasia is also referred to as expressive aphasia, oftentimes described as a motor injury aphasia. Okay, look at that. The patient is able to understand. However, the patient is not able to express. Now, the next type is your receptive aphasia. Class, your receptive aphasia is also referred to as your Wernicke's aphasia. So, class, this is a sensory problem, meaning they are unable to understand what you are telling them. And then other than that, since they are unable to understand what you're telling them, the tendency is that they have expression, but their expression is inappropriate. So it is not congruent to what you have said, because what happened is that they are unable to understand what you're talking to them. And then you have your mixed type of aphasia, also referred to as global aphasia. It's global because it's affecting both motor and sensory. So unable to understand, unable also to express their feelings. Okay, so class, the sad part there is expressive aphasia, because you know why? They understand what you're talking about. And as much as they would want to convey to you their own idea about your topic, they are unable to do so. Okay, or if they are able to do so, there is slowing of movement. Then class, other than that, other physical findings would be your kinesthesia, asteriognosis, and graphitesia. Class, when I say kinesthesia, okay, that's the sense of position of your spinal cord. Class, when I say stereognosis, okay, class, when I say asteriognosis, meaning you are unable to recognize the object placed in your hand. So examples of which is coin or key. Okay, class, your stereognosis. Okay, your stereognosis would be assessing your sensation, and then how familiar are you with the common objects. Your graphesthesia, on the other hand, is wherein the numbers are written on the hand of the client. That is for the client, that is for us to test if the client is able to discriminate between the fine details. Then class, you have your cremasteric reflex. Class, your cremasteric reflex is done by lightly stroking the inner thigh of the male patient with a tongue depressor. So normally the testicle on the side being stroked, okay, class, when I say being stroked here, the one wherein you had your smooth touch there. Now, it would expect that the testicle on that side will rise. If it did not rise, you would expect that there is upper motor neuron or lower motor neuron disease. Then class, you have your Babinski reflex. So class, your Babinski reflex, normally, you'd expect the toes to be turned inward. So you would document that one as Babinski negative. However, class, if there is dorsiflexion of your big toe and fanning, okay, beyond the age of 1 or 2 years old, you'd suspect an upper motor neuron disease. Okay, upper motor neuron disease. Remember, class, there is hyperexcitability of the reflexes in your upper motor neuron disease. Then we have your Brudzinski sign. So class, your Brudzinski sign and then your Kernig sign are signs that can be found in meningitis. Okay, so class, in your Kernig sign, okay, the patient is placed on supine position. Then you ask the patient, no, you are the ones who would flex the knees and hips, and then later on you would straighten the knee. Normally, class, there is no pain or resistance. Normally, okay, due to the extension of the spinal cord on the maneuver that you did, okay, according to the Kernig sign class, okay, you stretch the spinal cord and hence the resistance and pain could be felt by the patient. Okay, so class, for the assessment of reflex, these are the scoring mechanism that we are following in a score of 0 to 4 plus. And then class, for the levels of consciousness, you have your lethargy, obtunded, stupor, and coma. Okay, so let's look at obtunded. The patient will open the eyes to loud voice. They would respond slowly and they are seem to be unaware of the environment. On stupor class, you could awaken them, okay, with a vigorous shake. However, later on class, they become unresponsive. Okay, they return to unresponsive sleep. Coma, it's a state of no reaction at all. So no eye movement, no verbal movement or motor movement, or if there is class, it's very minimal. Okay, so meaning the patient is not responding to the usual stimuli. Okay, so class, again, a patient is considered to be in coma if the GCS score is 8 and below. Okay, those are some of the things that you need to remember in assessment. Okay, please proceed to the diagnostic studies. Thank you very much for your attention on this one.